we begin a lecture on the topic of thermal trauma. Burns will be analyzed in detail. So, what is a burn? A burn is damage to the tissues of our body. Mainly, of course, the integumentary tissues, and in severe cases, the underlying tissues, caused by exposure to thermal energy, chemical processes, sometimes electrical energy, sometimes insulation. Burn is caused by radiation energy. Thermal burns are usually classified into 4 large groups depending on the mechanism of their production. In more detail, we will analyze each of them later. So, thermal burns are divided into flame burns, burns with hot liquid, and in most cases it is still water and boiling water. Hot gas burns, most often steam, contact burns. Chemical burns are usually divided into acid burns, shallot burns, and burns with other chemical compounds. For example, it can be a salt of heavy metals, hydrogen peroxide, potassium permanganate, or something else. So, let's try to analyze thermal burns in more detail. Thermal burns by flame. The area of the burn is quite large most often. The depth mainly starts from the 2nd degree. This may be due to the fact that the flame temperature is usually about 300 degrees Celsius. During the primary treatment of the wound, that is, with FO, some difficulties are presented. Usually, the remains of burnt clothes, unnoticed threads of fabric can be found in the wound. All this can lead to the development of wound infection in the future. In case of flame burns, the organs of vision and the upper respiratory tract may be affected. Liquid burns are a fairly common situation, especially in pediatric traumatology. Children are very often burned with hot tea, hot soup, that is, hot liquid. The area of the burn is relatively often small. The depth is deep enough, 2nd, 3rd degrees. It should be understood that water does not have a very large heat capacity. Spreading over the surface of our integumentary tissues, on the surface of clothing, loses a fairly fast temperature, and burns are heterogeneous in their depth. Most often in the epicenter it is the 2nd, 3rd degree, and on the periphery it is the 1st degree. Burns with hot gas. Most often, it will still be steam. The area of burns is quite large. Burns are relatively shallow. This is the 1st, rarely the 2nd degree. Very often, the upper respiratory tract is affected by burns with hot gas. Well, burns, incandescent objects. The area is most often limited. It is limited by the size of the object. Burns have clear boundaries and are most often homogeneous in their depth. The depth, unfortunately, can be significant. It strongly depends on the temperature of the incandescent object. This can be the 2nd, 3rd, and 4th degrees. Additional injuries may occur when the object that caused the injury is removed. Very often, the object in this case sticks to the surface of the skin, and there is a separation of the damaged layers of the skin. Chemical burns. Acid burns. Burns are most often not deep. This is due to the regulating effect of acid, that is, on the surface of the burned tissues, a layer of pipes is formed very quickly, which prevents further penetration of the underlying tissue to the acid itself. Open work with concentrated acids is most often less deep, because due to the high concentration of C, the corpse is formed much faster. Burns with alkalis are much more unpleasant in terms of clinical course. Alkali affects tissue slowly, penetrates deeply enough, a barrier of coagulated protein is not formed, as in the case of acid. Burns with heavy metal salts. An example may be the mechanism of operation of lapis, that is, sodium nitrite in dermatology, when superficial skin formations are cauterized by this method. So, burns are usually superficial. In appearance, the clinics very much resemble acid burns. Electric burns. By itself, the human body is a fairly good conductor of electrical energy. The resistance is small, so the electric current can safely penetrate through our tissues. In the process of an electric burn, an entry point and an exit point of the charge from the human body are usually formed. With a high current and voltage, an electric arc with a very high temperature is formed between the entry points and the exit points. That is, in essence, it is such a form of existence of matter as plasma. A special feature is the presence of several burns of a small area, but very deep. That is, here is the distance between the entrance and exit. That is, this area most often burns to the 4th degree if we consider it as the depth of the burn lesion. Especially dangerous electric burns in the area of our ordinary tissues, which work on the principles of electrical excitation. In particular, burns in the heart area are very dangerous. By themselves, electric burns are very often accompanied by heart rhythm problems with the work of our heart muscle. Radiation burns, light radiation, that is, insolation burns associated with ordinary solar radiation occur most often in the summer. I think many of you have experienced this situation for yourself. Most often, the depth is small and mainly it is the 1st degree, the degree of depth. It is rare when you and I have a 2nd degree burn with the formation of blisters as a result of an insolation burn. Burns can also be caused by light radiation from any part of the spectrum. Depending on the wavelength, the depth of penetration also differs, respectively, and the severity of the lesion. The shorter the light radiation, the shorter the wavelength of the light radiation, the deeper the severity of the lesion. Short-wave radiation, which already has tonic properties, yes, here we have this X-ray radiation, this is gamma radiation. They can also cause burns. As a rule, they are not deep, but their treatment is very difficult due to the damaging effect of the study on living organs and tissues. Then there is an increased plane of blood vessels, bleeding, and the ability of tissue to regenerate decreases. But this, of course, is due to the very effect of hard ionizing radiation. There is a classification of burns by localization. Most of the burns are most often, of course, represented by burns of the skin. You can also find burns of the respiratory tract, which are very difficult to pass and in this case, aggravate the situation with the treatment of the patient. There are burns of the mucous membranes. A frequent example of this situation may be the ingestion of acids, in particular acetic acid, and suicidal motives. Naturally, there are combinations of burns of different parts of our body and we call them combined burns. So by the mechanism of getting a burn. Burns are usually divided into coagulation and colivation. Coagulation knife, or also call it dry. Necrosis occurs under 2 effects on the skin surface, most often acids, or high temperatures of more than 60 degrees Celsius. The damage in this case is superficial. A clear dark crust forms on the skin, which is usually called with a corpse, with clear outlines. The crust is sufficiently qualitatively fixed to the underlying tissues and is very difficult in terms of its separation and removal during surgical treatment. The contours of the burn odds correspond exactly to the same acid stain that got on the skin, or, accordingly, to the incandescent object with which contact occurred. Colquation burn is a wet necrosis. It occurs when the skin is exposed to alkalis, as well as temperature exposure with a temperature below 60 degrees Celsius. In this case, a more deeply damaging effect spreads. The spread is slow and gradual, rather than with acid burns. Colification necrosis looks different on examination, an uneven, blurred contour. Usually, if we consider the situation in the lateral section, then it is slightly pinched by contact and as an inverted cone spreading the damaging effect deep into its expansion. Collection burns flow much worse, require more serious surgical intervention and have more unpleasant consequences. According to the depth in our country, it is customary to classify burns into 5 degrees. The classification is quite old, 1961st year, adopted at the 27th Congress of Surgeons of the Soviet Union, and one of the few cases when the classification has been relevant and applied for so long. So, it is customary to divide burns into the 1st degree, when the upper layer of the keratinized epithelium of the epidermis is affected, and the lesion is functional, reversible, and as such tissue destruction, that is, filtration, does not occur. The second degree of damage to the keratinized layer of the epidermis in which it exfoliates, that is, the keratinized layer from the underlying layer of the epidermis. A bubble is formed in which a small amount of serous fluid accumulates. Third degree, there is already a fact of alteration, that is, damage and mortification of our tissue with you. The third degree is usually divided into 3A and 3B degrees. In this case, all parts of the epidermis are affected and the ultra-stimulating effect reaches the level of the dermis. At the third degree, the thermo is partially affected. The bottom of the wound is the intact parts of the dermis with the remaining and epithelial elements, that is, the remaining woody skin. If you remember from the course and the canteen, then the lower part of our own, let's say, multilayer developing epithelium, that is, the epidermis is represented by an uneven layer. Yes, we have papillary depressions in which in these areas, immersed in the dermis, there are those same skin cells. These are sebaceous glands, sweat glands, hair follicles, which subsequently contain rapidly dividing skin stem cells that can multiply and eventually we may have capitalization. Unfortunately, with the third B degree, there is a total death of the skin up to the term, up to subcutaneous fat, and these very areas containing stem cells do not survive. The fourth degree is a deep burn, in which the fascia, muscles, and bones are charred in the already underlying tissue. Accordingly, subcutaneous fat naturally dies. So the first degree of depth is damaged, as we have already said, in a functional way, the upper layer of the epidermis. This is clinically manifested by redness of the skin, slight swelling, and sometimes pain. Most often, the process is delayed for 2, maybe 3 or 4 days, after which a full recovery occurs. There may be a thickening of the surface of the epidermis and small areas of pigmentation may be left. Visually, during examination, hyperemia of the skin is determined. Subjectively, there is a feeling of heat, burning of the skin. More similar burns occur more often in people with a light skin type, yes, when exposed to sunlight. That is, this is the most common etiological cause of first-degree burns, that is, insolation burns. In most cases, there is marked hyperesthesia to both tactile effects and temperature effects. That is, it is quite difficult for a person to bring his hand to a hot and even to a warm object. Yes, that is, by hand, if that hand is burned. In general, the body can react in the form of a feverish state, and the reason in this case is a violation of the processes of regulating heat transfer and heat production. And in this case, a fairly effective method of treatment is the use of antipyretic drugs, even with small forms of fever. When we have subfebrile temperatures, we do not in this case have any great need to achieve a temperature of 38.5. Fever has a non-infectious nature. Most often, first-degree burns pass after independent conservative treatment. In most cases, I say again, it can leave behind areas of pigmentation, that is, altered pigmentation on the surface of the skin. A few people use it. The same tan that occurs in us due to the insolation of sunlight. So, the second degree of burns also refers to superficial burns, and in addition to hyperemia, the appearance of bubbles is noted at the site of exposure to the temperature factor. Bubbles with serious contents that arise due to the separation of the superficial, already dead keratinized layer of the epidermis from the underlying, containing living cells of the layer of our epidermis. Subjectively marked by painful irritation, also a burning sensation, pain. Palpation of the injury zone causes increased soreness, as well as increased temperature sensitivity. Such burns are most often still a product of domestic trauma, although they can occur not only from the effects of the temperature factor, but also from the effects of insolation. That is, like severe sunburn. So, the third degree. The dermis is partially affected, the epidermis is affected, but the wound is an intact part of the dermis with the remaining, as we said above, epithelial elements, the so-called woody skin. These are sebaceous glands, sweat glands, hair follicles. Shit after a burn, the damaged skin looks like brown, sometimes like black burnt from the pipes. Bubbles of a sufficiently large size may form, prone to merging with the contents of a serous hemorrhagic nature. Pain sensitivity is most often reduced. Self-recovery of burn data is possible. Therefore, burns still of the third degree belong to superficial burns. But the condition is that if the burn is not complicated by infection, there will be no secondary deepening of the wound. Burns of the third B degree already belong to the category of deep burns that cannot be capitalized independently. The death of the entire dermis is noted with the transition to subcutaneous fat, with complete total death of hair follicles, potoxal glands. Accompanied by deep burns, loss of pain sensitivity. That is, if we can still bark from the pipes and palpate the bottom of the wound during the Faux process, and there will be no combat sensitivity here. Because the recipes that carry out the vomit reception are located approximately at the same depth of occurrence, where those same woody skins are located, that is, hair follicles, sweat, sebaceous glands. The wound is usually covered with a thick layer of dark brown scab. As I have already said, independent regeneration is impossible in this case. When approaching the assessment of the situation of burns of the third A and third B degree, it is necessary to clearly understand the situation that there is a so-called giraffe effect, that is, the spotting effect. That is, in the epicenter, or in several epicenters, the burn may correspond in its depth to the third B degree, and at the same time, many areas of the burn wound may be represented by the third degree of burn. During the examination, in the process of performing PCLO, it is clinically very difficult to determine where the third A and third B degrees are. Therefore, in principle, it is possible for the epithelium to creep into the third B area from the outside, if these areas are small. In principle, the assessment of the state of the depth of the skin lesion can take quite a long time, but time. Yes, in the course of treatment, we will observe such a wound and will make our own assessments. That is, it prevails in our burn zone of the third B degree or the third a few words at the fourth degree of the depth of burns. The death of the underlying tissues is caused by the charring of muscles, bones, and fatty tissue under the skin. But wounds are most often not sensitive to pain. Burns are extremely difficult to pass, do not heal on their own and require serious, very long and repeated transplant operations. Moreover, if skin grafting is characteristic of the third degree, then in this case, that is, a skin, say, a fascial flap, then in this case it is most often necessary to perform a deep transplant. Yes, that is, if we manage with split wax at the third B, then we will have to use skin officially, skin muscle wax, that is, perform a deep transplant. International classification. That is, at the moment we are using with you the International Classification of the Disease of the 10th Revision. The ICD-11 was supposed to be imported on the way, but due to the latest phenomena in the world, the adoption of the ICD will probably still be postponed. It's clearly not up to import now. According to the International Classification, we have only 3 degrees of burns. This is a superficial burn, which corresponds, say, to our first degree burn. This is a partial burn. In our classification, a burn of the second and third degree, that is, it is a superficial burn, yes, but with alterations. And the third degree of the international classification is a deep burn of the third B and fourth degree in our Russian classification. Where is it 10 used? Most often, when encrypting the stress of insurance services, that is, with all the desire to know it, it is necessary to know and remember about it, too, is not required. Here at this wedding you are presented, just for the sake of interest, and a classification adopted in the neighboring state of Ukraine, which before that, of course, used the Soviet classification that we have left, yes, but now they have revised and they have a fairly good 4-stage classification, where the first degree is an epidermal burn, the first, the second is ours. There is a thermal surface third A, dermal deep on the third B, and a subfacial burn. A very concise and simple classification. Most often, when assessing the severity of the condition, when assessing the burn, when forming a correct diagnosis, the area of the lesion of our skin is necessarily taken into account when describing the burn. Here there are a number of rules that make it quite simple, of course approximately, but still determine the area. Palm rules, in which the patient's palm is filled with the patient, on average corresponds to 1% of the surface area of his, that is, the patient's, body. The method, of course, is not very accurate, because from different conditions, the area of the palm itself can have a fairly large spread. Here, on average, it is calculated from 0.78 to 1.2%. The palm area may fluctuate. Well, for a rough estimate of the area of this method is quite enough. Another simple rule is the rule of the 9 that you passed in the third year, in which the head, the surface area of the head has 9%, chest 9, back 9, live 9, lower back with buttocks 9, each thigh 9, each shin with a foot 9, each upper limb 9%. In total, we have 99% and 1% remains on the crotch. Well, it also allows you to approximately estimate the surface area of the burn. When applying the rules of the 9, one rather critical exception should be remembered. This method is applicable only for an adult. Here on this slide shows the change in proportions depending on the growing up of the child. That is, in a year, you and I have a head surface area of not 9 at all, but as much as 18%. Yes, at preschool age, at the age of 5, the area of the chapter is 14%, and only by growing up we have the same equidistant, let's say, proportions that were described in the last slide. So, in order to form the correct diagnosis of a burn and the registration of medical documentation, the diagnosis itself needs to include several mandatory components. The factor that caused the burn, the area calculated by the methods that were described earlier, and the depth in accordance with the classification. An example may be, for example, such a diagnosis: thermal burn of the right upper limb with boiling water with an area of 8% depth of the second degree. That is, a second-degree thermal burn of the right upper limb with an area of 8%. In cases where we have more than 10% of the burn area, such burns can be considered extremely dangerous and they can lead to the development of burn shock. We'll talk about this later. So, to assess the risks of developing burn shock as an extremely dangerous release of burn injury, and subsequently the development of burn disease as a systemic complex response to a serious burn injury, it is customary to use a number of indices. An example is the rule of hundreds, when the figures of the patient's age and the area of the burn are summed up. That is, this index up to 80 is considered favorable, after 80 to 100 units doubtful, and more than 100 units unfavorable in terms of the development of burn shock and risk to the patient's life. A rather subjective, simple index which assumes that the severity of the patient's condition depends on his age. That is, the older the patient, the more difficult it is naturally to endure a burn injury. Definitely the area of the burn is important. The larger the area, the harder the patient suffers the injury. This index does not take into account the situation that the child's age will give us a very small figure of growth in the index due to age. But at the same time, burns in children, especially the risk of developing burn shock, the risk of developing burn disease is much higher than in adult patients. We must keep this in mind, and there are several reasons. One of the main reasons is a small volume, a small area, firstly, the surface of the child's body and a small volume of circulating blood. That is, the risk of shock, which we talked about 2 lectures ago, in this case, with a small volume from the central committee, is much higher. This is also due to the fact that with any of the burns, plasma from the burn surface is lost quite voluminously. That is, the percentage of hypovolemia in this case is quite serious, both due to the direct edema of the affected and altered tissues, and due to the loss of plasma from the surface of our body. A more serious index is the Frank index, which takes into account the following. That is, in this index, 1% of the surface burn is taken as 1 unit. 1% of a deep burn, which is more severe, yes, this is the third B, and fourth degree, is taken as 3 units. There is an amendment in the presence of a burn of the respiratory tract, and it adds a fairly powerful figure of 30 units. With a total Frank index of up to 70 units, the forecast is considered favorable. From 70 to 90 doubtful, and more than 90 units unfavorable forecast. The signs of a burn of the very airways that we are just talking about now may be singed hair in the nose, soot on the tongue, on the teeth, hoarseness of the voice, cough, shortness of breath, wheezing in the lungs. Fibrobronchoscopy reveals soot, the phenomenon of tracheobronchitis, hypersecretion, swelling of the mucous membrane of the trachea and bronchi. So, it should be borne in mind that burn injuries are not only local tissue damage, not only a local small wound in the area of the damaging factor, but also quite often it is a complex reaction of the body to the damage received. Here is a complex reaction of the body can occur in the form of burn disease. This is quite a serious and formidable phenomenon. A little later in the next post we will talk about it, which can occur on the most serious burn injury. Usually, in terms of theology, it is required for the development of burn disease. If we have superficial burns, then more than a third of the surface of the body should be subject to superficial burns. With deep burns of the third, fourth degree, more than 10% of the body surface can cause burn disease in an adult. That is, it is burn shock and subsequent stages of burn disease. In childhood, as I said, the situation is much worse. 5% of the surface of deep burns can cause burn disease. In weakened persons with concomitant diseases, burn disease can develop after deep burns with an area of 3% of the body surface. Believe me, the burn is quite small in area. Burn disease in the course of its course has 4 stages of development. The first stage of burn disease. It lasts on average up to 2 days, sometimes up to 3. It's a burn shock. Burn shock, we will analyze in detail in practical classes, and burn disease as well. But in the course of lectures it is definitely worth mentioning. So, burn shock is essentially very similar to traumatic shock caused by a painful component, but a very pronounced hypovolemic component is added here. Hypermin here is associated both with the accumulation of fluid in the area of edematous, burn-affected tissues, and due to loss, as we already said, describing the last slide, losses through superficial damage, through our integumentary tissues are disturbed. The next stage of burn disease is acute burn. It to the family. Lasts up to most often from 3 to 12 days, in most cases around a week, occurs due to the entry into the blood of the decay products of the tissue of the burns. That is, those same altered destroyed tissues, if we have not fully performed the FO, have not cleaned our burn wound from the destroyed tissues, after some time begin to be absorbed. In most cases, it is not possible to perform a full-fledged FO in the case of a shock state of the body. Therefore, the stage of acute burn toxemia is formed. It is accompanied by toxic damage to the liver, kidneys, a rather serious fever, increasing anemia, leukocytosis, acidosis, that is, a change in the acid-base state of the body. With large areas of burn on the background of developing acute kidney failure, oliguria, anuria can develop, and as a consequence of uremia, general poisoning of our body is. The next stage, and not necessarily, is the burn septic tank of the same family. That is, a burn injury stimulates after some time all the links of our immunity. But the accumulated decay products, here in the first day, the same up to 12 days, cause poisoning of the body. As a result, our immune system is suppressed. The presence of a wound as such, the presence of damaged integumentary tissues contributes to the fall of microorganisms. In this case, a large measure of responsibility lies with the surgeons. At the right stages of performing primary surgical treatment, on proper, high-quality antimicrobial treatment of the wound, on performing full-fledged therapeutic protection, that is, work and antibiotics that will be used. That is, this moment from the moment of the appearance of suppuration to the moment of the beginning of healing is called the burn septic tank of the so-called family. It can last quite a long time, from several weeks to several months, but I say again, this is a rather optional stage of burn disease. After the burn septic tank, the recovery stage also begins, that is, the stage of consensions. It begins after healing, closure of burn wounds. Wounds are cleaned either independently or as a result of surgical intervention, but the wounds are covered with granulations, epilized. It all depends on the depth of the lesion. If we have deep burns, then as a result of our skin grafts, yes, we provide capitalization of the superficial wound and, as a result, healing occurs. Adverse effects of burn disease, in particular the effects of deep burns. All this can happen, as with compression syndrome, and the main stages are very similar to the pressure syndrome discussed at the last lecture. We can end this whole thing with the formation of scars, as a consequence of the development of contractures. This is one of the most adverse consequences of the development of burn disease. Although, of course, a burn disease can leave behind chronic kidney and liver failure, and so on. So, let's talk about the treatment of burn injury. First aid, which is usually provided at the burn site. In most cases, it is not even provided by a medical professional, but essentially by a person who will perform first aid. What does first aid include? Termination of the damaging factor on the victim, the care of rescuers, the care of firefighters, the care of any citizen. That is, extinguishing burning clothes, exposed body parts, removing the victim from the fire. Subsequently, in the presence of a burn wound, the application of aseptic dressing acutely and urgently raises the question of the introduction of analgesics already at this stage, because burn injuries, unfortunately, are extremely painful. In the subsequent evacuation of a medical facility, usually this is done by an ambulance team, and in this case the stage is called first aid. Control of anesthesia, the imposition of a high-quality aseptic dressing, often with the use of antiseptic agents. We will talk about the methods of applying such bandages for burns a little later. The beginning of systemic antibacterial therapy. Transport embolization should not be forgotten, because, for example, a burn lesion of a limb in cases of their subsequent additional traumatization when shifting the patient, flexion extension of this limb can cause very painful sensations and provoke the development of traumatic shock. Alkaline with strong-willed drink. We have talked more than once about the change to disappeared, about the risk of developing acidosis. Therefore, already at this stage it makes sense, firstly, to stimulate in this case the alkalinization of the body by alkaline drinking, and secondly, simply add a volume of fluid to the body, because losses will be inevitable. Prevention of hypothermia of victims is an urgent topic, especially if you and I have burns in winter. So, the next stage of rendering is the first continuation of the first medical care and the initial stages of providing qualified care. Usually, patients end up either in a trauma center or in the emergency rooms of trauma departments of small hospitals. What is spending here? Performs prevention of burn shock, unambiguous control of lethal functions, if necessary, contact with the venous canal and replenishment of the lost central nervous system. In case of burn of the respiratory tract, giving moistened oxygen, it is possible to perform a vagosympathetic blockade. So, we continue the alkaline salt drink. There is an assessment of the presence of tetanus immunization. If necessary, tetanus is injected with a toxin, tetanus antitetanus serum, begins antibiotic therapy and local treatment, that is, an aseptic dressing is performed. The issue of further treatment of the patient, that is, medical triage, is quite relevant. If in this case the patient is found to be easily burned, then it is possible to continue treatment in an outpatient trauma center. It is at this stage that the primary surgical treatment will then be performed, and the subsequent treatment by bandages. If the patient is found to be more severe, then hospitalization, a specialized trauma hospital will be necessary, and in the case of extremely severe burns, then to specialized combustological hospitals, which are arranged in our country by organizing burn centers. Burn centers are located by districts in our country. That is, in the Central Federal District, usually the city of Moscow, there are several centers there. In the classroom, we will disassemble this system. So, medical sorting involves severely burned people. These are deep burns of more than 10%, these are burns of the respiratory tract, these are burns accompanied by burn shock, burns of the eyeballs of the 3rd or 4th degree, that is, various combined lesions. In this case, these are severely burned people and they will definitely have to be treated in those ambustological burn centers. They will have skin grafts and complex operations. Moderate burns are deep burns of less than 10% of the body surface. These are surface burns of more than 10% plus, possibly, first-degree burns of more than half of the entire area of our integumentary tissues, limited deep burns of the face and large joints, which are dangerous for the subsequent development of contractures and cosmetic consequences for the face. The data in the case is definitely inpatient treatment, either in trauma hospitals where the patient will be hospitalized, or subsequently in burn centers. Uneasily burned ones are superficial burns of up to 10% of the body, isolated deep burns of a small area which can subsequently close themselves during bandages. And these are, respectively, first-degree burns of less than 50% of the body. This is usually outpatient treatment. In minor cases, the patient is hospitalized to assess the general condition, followed by a fairly quick discharge and follow-up treatment on an outpatient basis. So, the next stage, as we have already said, is the stage of qualified assistance. These are hospitals in which there are traumatology and surgical departments. These are central district hospitals, city hospitals, as well as the intensive care unit. In this case, patients will submit to the intensive care unit in the presence of traumatic shock. Yes, a full-fledged treatment of the same burn shock will be carried out, or there will be a preparation for the subsequent evacuation. The evacuation of the burn to the next stage is carried out after the end of the burn shock stage. In the process of burn shock, only about manipulations are performed, which are performed by a lifetime indicator. One of these manipulations is necrotomy, that is, dissection of circular burns. We will also talk about it a little later. The stage of specialized care, which we talked about 2 slides earlier. These are the so-called burn centers and combustological departments, which are organized, again, regionally, and where do patients with severe burn injury end up? In the nearest from our region. This is the All-Russian Republican Burn Center in Nizhny Novgorod, which serves the whole country, named after Nikolai Ivanovich Atyasov. This is the burn center of the Scientific Research Institute of Sklifosovsky, where quite serious scientific research is being conducted to develop new methods of treatment. This is the Scientific and Practical Center of Thermal Lesions of the Ministry of Health of Russia. This is the burn center of the Janelids Ambulance Hospital in St. Petersburg. This is a burn center at the Kirov Military Medical Academy in St. Petersburg, where assistance is provided to military personnel. The All-Russian Children's Burn Center is located in Moscow on the basis of the 9th hospital named after Speransky, and the Adult City Burn Center, which in principle accepts citizens from the entire central region of our country, at the 36th hospital named after Zemensky, is located. We must remember that the founder of the Russian surgery Inozemtsev was born here. He is our countryman and was born in Borisogledski. So, as I have already said, the All-Russian Burn Center, located in Nizhny Novgorod, bears the name of Nikolai Ivanovich Atyasov, an outstanding fatherland resuscitator surgeon, who for a long time, quite in 1972, processed the entire body of knowledge on kabastology, resuscitation, formed and developed a system of active treatment of severely burned. All the components of active treatment which are included in this scheme are presented here at this wedding. Please actively, clearly disassemble them. In the classroom, we will prepare a report on the activities of Nikolai Ivanovich Atyasov, and a request to comprehend what was offered to them quite a long time ago, in 1972. Let's try to talk specifically about the treatment of a burn wound. First-degree burns in most cases do not require any local treatment. In order to prevent subsequent peeling, subsequent temporary changes in pigmentation, ointments can be used. Ointments in this case will also facilitate the general condition of the body. Any ointments, creams containing superoxide dismutase will allow you to quickly pass the first-degree burn stage. In the absence of ointment, you can use folk methods that are quite effective. This is sour cream, kefir. But the ideal option is still, probably, foam will be considered. Panthenol foam. And remember, there is such a form of release of this drug, which very effectively helps with first-degree burns. Second-degree burns. There are several approaches to the treatment of these blisters. Moreover, one of them, quite widespread in our country, is definitely harmful and false. Let's talk about it. There is no need to do such a situation when the bubble is pierced with a needle. Sometimes even a sterile syringe hoard is taken, yes, or the liquid is slightly incised and released from under it, and in this case the remaining bubble cap goes under the bandage. What can happen in this case? And three things. The first thing is that a slightly small hole will just overgrow, close, the liquid will be stingy again and we will get a bubble again. Prolonged existence of the bladder can lead to its inflammation, suppuration. Another option is that we have a larger hole. The liquid is critical, we have wet, warm under this lid and this is a reason for the development of infection. In addition, we have opened a way for our infection, we have completed the hole. Well, the third, most frequent option is to separate your epidermis. It is already dead, it is already keratinized, without the presence of this moisture under it, which has accumulated in the bubble. After literally 2 or 3 hours, the surface of this lid will crumble, turn into a rather coarse crumb that will irritate the underlying tissue, yes, in the form of deep layers of the epidermis and dermis, where we have pain receptors, they are alive in this case. This will cause us increased soreness and extremely unpleasant sensations. How to approach? The ideal option is large bubbles. This is the work of a surgeon. That is, in sterile conditions, a dressing room or an operating room, there is a pH of burns of the wound, the removal of the detached epidermis. Most often, it is either cut off in vertical sets in a circle, or simply torn off if there is a surface, let's say, a shallow, not thick layer of exfoliated epidermis, after which I apply a sterile aseptic bandage. Another option is possible in the treatment of small blisters. Bubbles with a diameter of about 1 centimeter. Their integrity is preserved, but such bubbles require observation. Why? Because if the bubble is fresh, it literally took him a few minutes, an hour, 2 hours, there is a great chance that the next day the bubble will already take you a large volume. If the bubble is not fresh, it has been for several days, then you should not worry about it. They usually retain their integrity under a bandage and in this case a thick, greasy ointment is used. Ointment with antimicrobial effect. We will talk about these ointments in the following slides. So, let's talk about local treatment of burn wounds. We have already talked about first-degree burns. The second, third aid, surface burns, as well as first aid for any form of burns requires the use of antiseptics on top. We can present antiseptics in liquid form, in medicinal form, or in soft form, that is, in the form of ointment. It has been said more than once with us that burn doctors are very fond of ointment forms after all, but again, at the stage of providing subsequent assistance, that is, at the stage of further treatment. At the stage of first aid, we usually have liquid forms in first aid kits. The drugs of choice in our case will be, as with a normal wound, hydrogen peroxide and orgexidine. Things are affordable, things are cheap, things produced in our country that do not require special storage conditions, do not require any difficulties with packaging. That is, an ordinary plastic bottle, although in fact, of course, it will be possible to use both meramistine and dioxidine. Here, on this pile, they are tinted with a different color. In the case of getting into it, in the case of a small burn under the corpse, in principle, you can use diamond green. But again, in this case, the alcohol-based drug is probably not very convenient here. Ointment forms are represented by a fairly large set of different types of ointment, starting from the ancient proven furacillin ointment, which is usually made in medical institutions, own pharmacies, ending with modern herbal preparations. The drug chosen in this case will probably be dermazine. It is also performed by a slightly different company. Well, it has the name isosulfate. The drug is wonderful. It is represented by silver sulfadiazine. That is, silver itself has a powerful antiseptic, powerful reparative effect, and sulfadiazine has not lost its importance as an antimicrobial agent. Let me remind you once again, superficial burn wounds are treated fairly well and qualitatively with the help of ointment forms. This allows us to injure the granulations to a lesser extent when changing the dressing. The bandage adheres to the wound to a lesser extent. The burn wound itself does not like frequent dressings when dressing. The more often we bandage, the more we will injure the granulations and the longer the wound will heal. Plus, ointment forms allow, by creating a film on the surface of a burn wound, to reduce the loss of plasma, to reduce the loss of fluid that will go into bandages or into the external environment. Unfortunately, most medical institutions use levomecal. The drug is not fat-based, but water-based. On the one hand, it is cheap, it is stored well enough, but on the other hand, recently there has been a clear feeling that, like an antimicrobial drug, like a drug, it is a rather outdated and old thing. For the first degree of burns, we have already said, a fairly high-quality thing is foam. Foam preparation panthenol. Let's try to consider modern means, local for the treatment of a burn wound, the so-called mesh, in the next piles. The mesh base assumes a fairly convenient next moment. The mesh applied to the wound allows the granulation tissue to develop in the cells of this mesh. The grid remains long enough to lie earlier. Only the bandages above it are replaced. Bandages can be impregnated with antimicrobial agents, various variants of ointment forms, but the mesh itself remains lying on the wound, and this allows us to injure granulations to a lesser extent and avoid a pronounced painful component when separating the stuck bandage from the wound surface. Domestic grids of Russian production will be presented here. One of them is Parappa. Pay attention to him. The mesh is based on a cotton base. This is probably the initial level of development of such wound treatments. The paraprane mesh can be impregnated with various variants of medicinal substances, in particular the antiseptic chlorhexidine, a possible option with lidocaine impregnation, which reduces the pain component about wound treatment. And the moment of using chymotrypsin as a filling drug is quite interesting, namely in the paraprane. The only one, probably, such a drug is at its core, which allows us to fight with a rough, tough corpse. That is, such a mesh superimposed on a corpse, which is rough, which is very difficult to remove by acute means, allows you to literally soften it in a few days and bring it to a state where secondary surgical treatment, that is, secondary necroectomy, will be performed without any special technical difficulties, and we will be able to remove this stroke quite carefully from the surface of the burn wound. A more advanced drug in the treatment, more precisely, a means of dressing, is a wax-based mesh. Wax itself, as a product of, say, beekeeping, has a fairly large set of remarkable medicinal properties. In particular, this is a good drug. Plus, the wax that melts in the wound, in this case, allows this mesh not to stick to the surface of the wound. That is, it additionally provides softening in the wound area of the dressing process, provides greater safety for developing granulation tissue. The wax grid happens to be with an option, the cheapest of them is with the left stakes, and honestly, I don't really like it. A remarkable variant of Discopran is a Hycopran with dioxidine, a very powerful drug with remarkable antimicrobial properties, but with one bad property. After all, dioxidine is a teratogen, a powerful teratogen, remember this. It is perfectly used in children, the elderly, men, but in the case of using this drug in a woman of fertile age, you should definitely ask yourself if she is pregnant. Also, Buscopan is available with methyl ointment of 10%. That is, in this case, the purely reparative effect of an old proven drug. But if we have a bacterial complication, that is, an infectious complication, then such a mesh should definitely be supplemented with antimicrobial ointment on top. Pay attention to a number of the same mesh wound dressings that we have on our medical market. The grid is about the floor. She is often provided with an ambulance. A special feature is myrmestin in gel form on a cotton basis. A large volume, that is, the grid is most often a very large area, and it is very actively used to provide the very first aid. Another interesting thing is the Branolite mesh of foreign production, the Hartmann Company, and, probably, it is now at the moment the most common of mesh wound healing dressings. Much more common than the domestic Hi-Rise and Parap. Therefore, the price group is somewhat cheaper. A very peculiar base is a Peruvian balm. The composition, in fact, I do not know, but the grid is effective. The grid is widely used. The mesh contributes well to the healing of burn wounds, the duration of healing trophic ulcers, various wounds on the background of diabetes, infected wounds. The next type of modern wound dressings is gel-based bandages. The domestic version is the so-called gel pran. That's what is presented here on the slide. Quite an interesting form of release in the form of a gel that allows you to stretch, lay on the surface of the raw wound and apply a bandage on top. This gel is on the surface of the wound for a long time. This is calculated according to the instructions for several days, up to a week. Gradually melts, gradually gives off medications, does not allow the bandage to stick to the wound. Kilipan happens with myrmestin as an anesthetic, well, a means of anesthesia with lidocaine. There is also an interesting form of gelipran with silver produced. There are imported analogues of gel dressings. The most common one they have from the Hartmann Company is the same. This is a hydrosorb. It can be made using the same gel plate superimposed on the wound, or a gel in a syringe that is directly applied to the surface of the wound, smoothed over it and, accordingly, bandaged with a septic bandage from above. There is also a hydrotac option. The variety of modern, previously healing agents is quite large now. The market is constantly changing. You should keep an eye on these things. A very interesting domestic know-how is a wax sorb, that is, it is essentially a wax membrane. The deposit is located on top, which contains a sorbent, that is, activated carbon. A very interesting mesh that allows you to treat inflamed purulent wounds and provide sorption, direct absorption from the wound of those same altered toxic products. Another remarkable product made by the same company that makes the wax is the so-called polyp. People sometimes call this thing artificial leather. A polymer film that is applied to the wound and provides selective permeability. That is, the liquid in this case penetrates only from the outside. From the inside, we block the loss of plasma, the loss of fluid directly from the surface of the wound. The air penetrates in both directions. That is, the polyp, being on the surface of the wound, allows us to exist for a long time before. From above we can apply bandages containing antiseptics, repellents, and at the same time actively not to lose tissue fluid, not to lose plasma. Where does the law field apply? Most often in the process of preparing the patient for a skin transplant directly. When some areas have already been cleared of scab, and some areas still require some kind of monitoring, cleansing from scab, for example, fighting infection, yes, or assessing the quality of blood supply to the underlying tissues. And normal areas can already be treated, wait and, say, hope that we will transplant the skin. Here you are. For this period it makes sense to cover them with such a film, a polyp of the so-called temporary artificial skin. Polypan also happens to be impregnated with certain medications, for example, with dioxidine impregnation, a very powerful antimicrobial agent, or with lidocaine impregnation. We are moving on to the surgical treatment of deep burns, which are used surgical operations in the treatment of burns of the 3rd, 4th degree. In this case, the operations are mandatory. Independently, the skin cannot recover with such deep burns. In the treatment of burns of wounds, the following necrotomy operations are used. Yes, we'll talk about her at the next wedding. Previously, necroectomy. Do not confuse the phrase, the term necrotomy itself, that is, it is the dissection of incapacitated, deceased, burnt, altered tissues, and necroectomy. Ectomies are excision, removal of them. And so earlier necroectomies with immediate closure of the wound surface by transplantation of the patient's own skin or temporary imposition of AVA or heterosplant or synthetic skin. Let's say we talked about this at the last wedding, until the moment of autodermoplasty. And the third operative benefit is delayed skin grafting after conservative treatment of the wound, after rejection from the corpse, yes, perhaps after healing from the infection that has joined. So, necrotomy dissection is gentle from similar deceased necrotic tissues. An indicator for its use is the formation of a dense circular burn necrosis, which, like a shell, covers either the limb or the chest, causing a violation of blood circulation, for example, or a violation of the respiratory movements of the chest. Necrotomy is performed without additional anesthesia. You understand, in this case, we are already cutting a dead tissue that does not have any nerve endings. It consists in dissecting the scab to the full depth until the appearance of blood droplets, that is, unrepeated dissection. Across this very ring, which circularly covers our segment of our body, we must dissect. When performed correctly, the edges of the incision diverge and we provide decompression of this zone. So, the next type of surgical aid for deep burns is previously necrectomy with closure of the defect of the affected skin. Usually, the duration of spontaneous rejection of necrotic masts healing of a burn wound, well, depending on the localization, on the depth of the burn, is from 3 to 5 weeks, sometimes more. During this period, there is a great danger of developing various complications associated with the method of loss, with intoxication of the body, with the development of secondary infection. Therefore, when early determining a deep lesion, one should still use the principle of early release of the burn wound from necrotized tissue, possibly as early as possible closure of the defect by a skin graft. It is not always technically possible. Sometimes we are hindered by the general condition of the body, that is, the developed burn shock, burn disease. Sometimes, in terms of logistics, the patient is directly in a place where there are no technical capabilities to perform such complex and so specific operations. It is far enough to transport the patient to the burn center, and at the same time his condition may also not allow it. But it is necessary to strive for such a method. The advantage of this method is the removal of necrotic tissue, which is the main cause of intoxication as a result of absorption, as well as the soil for the development of pathogenic microflora. All this makes it possible to reduce the level of plasma loss, significantly shortens the course of burn disease, prevents the development of infectious complications, accelerates the healing period, an equal period of hospitalization. Early activation of the patient improves his general condition, the rapid return of a person in the construction of a social unit of our society. There is no need for frequent painful dressings, the possibility of the development of rough scars, which subsequently invalidate the patient, decreases. So, earlier necrorectomy is a major surgical intervention. Its implementation is fraught with the danger of prolonged anesthesia with profuse bleeding, and it is most advisable to apply early necrorectomy somewhere for 3-5 days. That is, when we guarantee the absence of burn shock, we have stable hemodynamics. There are two ways to remove dead tissue: tangential, lead, when the tissues are dissected in layers before the appearance of capillary bleeding and each time the superficial ones are removed. Either instantaneous, immediately expire to obviously viable tissues. In this case, a special tool called a dermatome is usually used for this purpose. After necrorectomy, it is necessary to close the wound defect. In rare cases, with local burns, it is possible to suture and close the defect with the help of plastics with local tissues. But in most cases, skin grafts are done. Basically, free leather plastic is used with a split skin flap, whether perforated or not perforated, or with deep burns, which are of the 3rd degree and degree. Plastic surgery is performed on vascular legs. Yes, cutaneous and facies or musculoskeletal flap. A little further on, you will be presented in detail the types of these types of operations in the form of video fragments. Please view and understand them in more detail.
Deep burn of the foot and lower leg. During therapeutic and diagnostic necrotomy, necrosis of the entire thickness of the skin was revealed, along with clinical signs of warming up and damage to the underlying soft tissues of the foot. Performing an early necroptomy using a general surgical set of instruments. An application option for the same purposes of an electric dermatome with a DS40 nozzle is the layer-by-layer removal of necrotic tissues on the plantar surface of the foot. After the burn, there are sluggish wounds, the hand and forearms. Tangential sections of sluggish granulating forearm wounds with an electrodermatoma with a DS60 nozzle. Replacement of interchangeable nozzles. Instead of the nozzle D60, a nozzle with a smaller diameter of the working part to 25 is installed. Tangential excision of granulating wounds of the fingers with an electrodermatoma with a D25 nozzle. Cutting of skin flaps with an electrodramatum with a DS-STU nozzle. Plastic closure of finger wounds with non-perforated split flaps. Obtaining a mesh skin flap using a perforator. Plastic closure of the forearm wound with perforated split flaps.
Another method of treating deep burns is delayed skin grafting. The method is used after conservative treatment which ended with the rejection of the scab, and possibly under the pressure of a developed wound infection. Skin grafting is possible when the wound is covered with granulations. There is no pathogenic microflora on its surface which can be confirmed by seeding on a sterile surface of the wound. It is usually advisable to perform skin grafting about 2 to 4 weeks after receiving a burn. This technique is more gentle, less traumatic, although it has its own negative aspects too. Firstly, it is the duration of treatment and suffering for the patient. The development of intoxication about the possible development of infectious complications associated with the period of rejection of necrotic tissues, as well as significant plasma loss. Phase in treatment with tearing of the right leg. The Do-un recipients are being dressed with various complications of burn wounds are presented on this layer. These are the primary complications that can occur directly at the time of receiving a burn wound. Secondary complications are mainly infectious complications, which are sometimes also called secondary early complications, which can haunt any wound, including burn and up to the generalization of infection. And secondary late complications, which can also lead to subsequent disability of the patient, to a prolonged deterioration of the general condition of the patient and subsequent incurable phenomena. Here is one of the early complications of electrotrauma. In this case, in the presence of a pronounced electrical injury, when a person is struck by a large current with a high voltage. Well, in particular, this character most likely received an electric injury in a high-voltage electric burn. There is also a release of mechanical energy with the separation of limb segments. This is one of the early complications of burn injury. The last slide shows one of the know-how. This is a special anti-fire bed. Once the Kleinetran company was a monopolist in the manufacture of these beds, and now there are already our domestic, Russian analogues. The essence of this method of treating severe burns will be understood by us in practical classes in the form of a report. But in the volume of lectures, 2 words should be said. A bed of the Kleinetran type, a special anti-burn bed, allows you to lay a patient burned as, let's say, seriously burned from different sides. And in this case, there is a direct contact of this membrane on the surface of the bed with the burnt surface. Through this membrane, let's say, exudate is passed, natural human feces and the sorbent component that is located under this membrane, respectively, allows the whole thing to be lumped and removed. Plus, a weightlessness condition is created from below. That is, the character has, say, a bed has a temperature of 36 and 6 degrees Celsius and is comfortable enough in terms of the stay of a severely burned person.